what we'd like to do, we would have gone through the minutes, and there are a number of other motions that we were hoping to get through today. But I am going to move forward and introduce Nick Macchione. And, what we will end up with today is really an opportunity for both a presentation about what's happening with Live Well San Diego, and, just an amazing opportunity, I think, for those of you that are here to have some dialogue with Nick. At our board retreat in January, we began talking about the role of the ACH looking beyond the Medicaid Transformation Project. And it was during your presentation at the Public Health Association conference in October that several board members who were there in the room actually reached out to me and said, this is exactly what the North Sound ACH board, could really benefit from hearing. So there actually had been a request that Nick join us during our board retreat, but it was the homeless count in San Diego County, so January did not work, but he set aside today, and so just really appreciative of that. So I'm going to read a little bit from your bio. Just know that it's like some, but not all. So mostly I just want to, I think that the most important piece that I heard, that you've just passed like 10 years of this 10-year journey around Live Well San Diego. He has a workforce of 6,200 employees, $2 billion annual budget, 166 citizen advisory boards. So don't listen to that, Tiffany, because we're doing stretch with like 7. 1,000 contracted community providers, and they are one of the largest health and human services networks in the nation. And that's like amazingly larger than what we're talking about here in North Sound. But it really was talking about this progression of what was referred to as a social movement around Live Well San Diego, what it has taken to get to that type of a collaborative environment from a very kind of segmented, siloed set of entities around the county. And just as we were walking through that and listening to that presentation, we just kind of said this would be incredibly valuable for our board to hear as we think kind of looking out into the future. So, with that, I'm probably going to turn it over to you, and thank you again so much for being here with us.
It's an honor, and good morning. And thank you really, Liz, for the kind remarks, and Tiffany for all your help. I have to say, is that on? Am I okay?
Oh, you're
okay.
Good. Oh, okay.
And I'd like to make this more conversational. I could stand if you like, but what the idea was to, for the visual learners, I'm one of those, is to kind of go through a little bit of the journey. We are kindred spirits. We are kindred spirits. We have a lot of the same health plans in San Diego. We have a lot of the same issues. And you'll hear in a moment, even our geographics, from our military to rural to Native American Indian sovereign nations to urban core, we have a lot of similarities between San Diego County and Washington State. But first and foremost, I think it's that we have deep purpose and passion in our work and what you do. And I should tell you that I know this for a fact because a dear friend of mine is State Senator Eileen Cody. We serve on a national board. You all smile and laugh. And I think she's finishing nursing now. I think she told me she's going to do that. But we were talking about the ACHs before they were formed. And hearing from Eileen and the work and seeing about how the CCOs in Oregon and what was happening in Massachusetts and learning from others. And so what was exciting for me, because we also have ACHs, and I'll talk about that in San Diego, in California, not through our Medicaid, through non-Medicaid, a voluntary program. So we'll talk about how we keep that together. But what was exciting to me about, obviously, is how you were creating this all-inclusive vision around wellness. And clearly, of all the ACHs in Washington, you're like hitting every one of the marks as I was looking at. So you're the true north for all of the state, if I could, in terms of your plan and what you're attempting to do, are doing. So that's one. The other, healthcare is all local. So we love, and Sue Birch is a dear friend, and she was Colorado and also on a national board. And but it's actually Commissioner Ken Dahlstedt, who's a dear friend of mine, and we served together in the National Association of Counties, an amazing ambassador and promoter of your work. And we're kindred spirits. And so there's a lot of connection between leaders here and what you're doing, the work I've, from afar, watching what Liz has done and has been doing. And so I don't want this to sound like San Diego has it. We need to, let's make this a case study because we're all on the same journey, right? So I'd like to put out there some things that we're doing, maybe a little provocative, a little bit stretching the boundaries of thinking from an organization. And I was asked to talk about how we're operationalizing the vision around population health and well-being, what we're doing here. And so I will get that. But to get to that and to give you really the context is how it evolved. Because all of this is about culture change. All of it is about culture change. Initiatives, programs, reports to the state, all those things in it, but it's about culture change that we're laying down, what you're laying down, right? And so to give you that groundwork, I think I'm going to share a little bit about our agency and how that informed our work, our workforce, our partnerships to where we then are today. And then we'll open it up for really the dialogue, I think, which is the key. And I will also say that my wife works for a county government. She's in vacation. She's not her first capacity. But she is an attorney representing Health and Human Services. So I don't have her here to provide any legal advice for me, but she's also a kindred spirit in the work that she does for the County of San Diego for Health and Human Services. So we're going to talk about this concept of generative, because that's what we're doing. And there's a Harvard model, the value curve, if you're familiar, that talks about to improve efficiencies and effectiveness, you have to move boundaries beyond the regulatory state to a collaborative state, to an integrative state, and then to what is a generative state. And this generative state it's once we're integrating, we're going to solve problems we did not even know existed because we're integrated. And so your model of this fully integrated health system is a challenge. But understand by doing that, you become much more generative. And I'll give you some real concrete examples of where we experience it. And the truth is, you have to be all stages, right? Regulatory for reporting that the state has and needs for us, to collaborative, right? Collaborating with Providence, collaborating with our hospital systems, FQHCs, and everyone else, to integrating with those that believe that are at this table, to being generative. So that's the path, really the ecosystem space that we're pursuing in San Diego, which I believe you are as well. So here's San Diego. As I was saying, there's a lot more similarities than differences. Everyone thinks, Seattle, San Diego, homeless. Yes, we have a homeless problem. We have a housing crisis. And more importantly, homelessness is not helpfulness, right? And so we're restoring hopefulness in this concept and the work that we do. So we talk a lot about our vulnerable population, but we are a very diverse region. In California, we speak over 300 different dialects. In San Diego, about 60 different dialects. Right now, we have Central American families coming in where we have asylum-seeking families that we're providing a shelter to, temporary shelter. We've had the Haitian immigration. We've had Eastern African, and we have Chaldean community from Iraq. We have great diversity and growing in San Diego. Well, but people don't know is San Diego is a designated rural county. 4,200 square miles, right, the size of Connecticut, larger than about 6 states, but it's a rural county. Why? Because we have so much agriculture. In fact, one of the largest women-led farms in the nation. We also have 18 sovereign nations, Indian sovereign nations. Probably one of the greatest number of Indian sovereign nations in a concentrated area. And so when you look from coastal communities to inner city, to mountain villages, to desert towns, that is a very diverse ecosystem which you experience here in Washington State, right? And so how do we bring and celebrate that diversity as a strength? And so we have taken that as also military town, and how do we take that and how does that help us, if you will, with our movement around social well-being? So I'll illustrate some of those examples. So this is just a snapshot of who we are. Liz, I think, covered it. We've grown a little bit, and we're growing even more. Governor Newsom, just in his January budget, has announced some really exciting things like taking juvenile dependency and probation and putting that under Health and Human Services, taking restorative justice and making it more what we do in terms of health and building the human capacity, people, well-being. So our agency is growing, even from our current position. But we We're a 5-member county elected board, similar to Commissioner Dulcet. We have 5 board members that I report to with the CAO, Chief Administrative Officer. You'll see the population. What's important is that our agency, unduplicated, serves 1.3 million San Diegans across our programs in terms of our fully integrated health system. And I'll show you a snapshot of what those programs are. We've really adopted a lot of the modeling that Vermont has done with their substance abuse hub and spoke system and taken that for the entire Health and Human Service Agency. So we really see ourselves as hub and spoke approach system. And why that's important is that, as you know, Colin's flywheel example, it gets stronger as you increase the spokes, but the hub is the person-centered, population-centered work, right? In our case, achieving wellness for all San Diegans. So as you create this hub and spoke, you then start looking at these kind of large-scale population improvements around dealing with health equity or health inequities, right? And dealing with issues around safety, and I'll hit on some of those. So Liz touched on that. We have moved and evolved from initially being program-based, right? The list of all the different programs you have to do for your ACHs or your respective organizations, and move from that mindset to more of that community-wide social movement. How do you move from programs, initiatives to more holistic planning? And that's hard work of how you maintain it, sustain it, and grow it. That's hard work as you're experiencing, as we're experiencing. But that's the journey we are on as an organization. Okay, one spoke among others, as you'll see in a moment. So this is, we refer to ourselves as an agency of one. We have a county government, about 17,000 employees, and that's public safety, that's land use, that's the finance groups, the Health and Human Service Agency, which includes housing. We incorporated through ordinance change about 3 years ago, housing as part of Health and Human Services. So I wanted to rename ourselves H3 because I thought it was cool, Health, Housing, and Human Services. But they said that was like two Star Wars show. They said no. So we're Health and Human Services, but it's housing as well. So I'm the Public Housing Authority for the County of San Diego. And that is, and I'd love to talk about that because if housing is not part of this, it is paramount importance because it changed for us, our housing authority's mindset of bricks and mortars to human capacity first, and bricks and mortars the means to an end. So, but these are the different programs we have that we provide, including some inpatient care. We have a now 92-bed, 103-bed psych hospital, 192-bed skilled nursing facility, lots of outpatient, and we contract, which is the difference here, we contract for acute patient, inpatient with our hospitals. We do not have a county acute care general hospital. We contract that. And so there's, happy to talk about the strengths and weaknesses of that model, but it still incorporates those contractors that we fund in serving those 1.3 million San Diegans. So let me quickly tell you our journey, and I'm sorry you can't see the kind of the top, but you would see it as 1998. Oh, do you see it right there? So we created the Health and Human Service Agency, the Board of Supervisors, interesting bookends. In 1995, it was the Temporary Aid for Needy Families, AFDC, for those familiar, to TANF. That was welfare reform. And so I say that because we're at the bookends of welfare reform and health reform. And I think health reform is still evolving, right? But welfare reform, the mindset was, how do we put some constraints, make it not an endless program? How do we get people on their feet and self-sufficient? How do we provide the supports so parents can support their kids and be more self-sufficient than on public assistance? Because we know that codependency wasn't really getting people lifting out of poverty, which is a key issue in terms of dealing with population health. So TANF was a game changer for the entire nation, Washington State, California. For us, we took the opportunity to say, well, how will we achieve all these array of services that families need? And this is for illustrative purposes, but in some cases a real reel of these different programs. And so how do we move and bring these services together? And that was the catalyst that created the Health and Human Service Agency. And I joined from back east in San Diego in 1997. So I've been the last remaining of the executives that helped create this agency and actually served as one of the original deputy directors until about 11 years ago when I became agency director. But I can tell you, going through that journey, it was really this decade, we call it decade of excellence, and decade of failures, lessons learned. Of course, we always put the positive, but I'm giving you the underbelly. A lot of failures we had, right? It felt like the wild, wild west. There was no playbook. Did you have a playbook when you had your ACH? Not really. You're creating your playbook. Well, for us in 1997 and 98, there was no playbook. How do you create this super health and human service agency? At that time, about 7,000 employees. We actually compressed them over time because of efficiencies. But I talk about this as this was the culture change. It was moving, very importantly, beginning the movement of the fidelity to the professions to fidelity to the cause. This is extremely important. What does that mean? The fidelity of I'm a managed care administrator, I'm a public health nurse, I'm a social worker, I'm a physician, I'm a eligibility technician, or whatever profession, and saying your fidelity is not to your profession. That's great. You got those skills, talents, and treasures. But your fidelity now is to improving the lives of the people we're touching. And shifting that was a challenge because managed care did it this way, public health did it that way. At that time, we had co-occurring. We didn't even have behavioral health, right? We had substance abuse and mental health, and now we have behavioral health. So everyone had their own fidelity to how they were going. And so the culture really here was, wait a minute, if we're going to be trauma-informed, we weren't using that phrase. If we were going to move from no wrong doors, that was the expression we were using, which frankly we had too many doors. But if we're going to be trauma-informed, if we're going to become this agency of one, if we're going to take 60 different logos, I kid you not, 60 different logos under the same agency, I'd go to meetings and I'd be like, oh, you work for the agency? I didn't know, based on how they were presenting themselves, right? You all have different logos. You have all respective different organizations. But when you come here, you're the North Sound ACH, right? So this was it wasn't branding. It was winning the hearts and minds of workers. And I had the best part of the county. I was a deputy of the north part. See, I have an affinity for the north. And so the north, which was more rural, much more Everett kind of, Washington, was where the greatest innovation, because when you have rural and Indian sovereign nations, you don't have all the resources, right? You have each other. And so I found the greatest creativity was the fact that we had a belief system. And in this 10 years in the northern part of the county, where I was the deputy, we created something called the North County Collaboratives. It is the equivalent to your North Sound ACH. We did it from 1998 to about 2008. And it was multi-sector, transportation, faith community, cities, and it was, at any given time, our board meetings would be about 60 different organizations, okay? Very challenging to do, and we, the county government, funded the staff. So I'm going to talk about that because we funded, county government funded. I'm not proposing to any of the county governments here or on the phone, you have to do this, but we felt the importance of providing the administrative backbone support for the North County Collabs, who then flourished and got grants and then did some, really the enabler for the other nonprofits and a few for-profits, because we had some business chambers, which is really key to have. And our where we learned about faith community and the business chambers was in our work in our first 10 years. How critical the business community was. Business association, economic development councils, and the like. But what this did for us was creating this common sense of an organization. What we didn't have, though, we didn't have our North Star. We didn't have our vision, meaning we had a mission statement, making people's lives healthier and more self-sufficient, but we didn't have a plan. Our plan was to work together and work collaboratively with our community. And so our eyes got awoken because this is where 2008 was. We did a better job, this is for illustrative purposes, but I could give you concrete examples of how substance abuse and mental health co-occurring became behavioral health. That's great. Behavioral health, we began our integration journey of talking about where is our psychiatrists in our FQHCs, Federally Qualified Health Centers. We began the journey of how are we managing and I'm looking through our plans, Melina and all our great friends, how are we handling the severely, we're carved out in California, our severely mentally ill and our mild to moderates that our plans were managing through our FQHCs, but we were doing a little bit of this. But beginning to bring together, that's a cute puppy, beginning to bring together these pieces, and they were friction points. They were real friction points. But what I'm really sharing here is the first 10 years was how we were bringing this whole bundle of health-related services together, having tuberculosis, TB program, and STD, talking with our managed care, Medicaid managed care, and FQHCs, how we were already opening our eyes to behavioral health and the concept of mental well-being and dealing with stigma that had to be lifted by not just mental health or behavioral health, by all programs. So, and on the social service side, I kid you not, we had buildings where child protection services, and we called them, at that time now, we call them our family resource centers. Back then they were called income maintenance, welfare, right? How they were on the second floor, first floor, they didn't know each other. They didn't know, they were in the same agency. So we said, wait a minute, you are providing the self-sufficiency of families. You are all involved, the fidelity to eligibility and getting it right on getting people access to food and signing them up for Medicaid. In our California, we call it Medi-Cal. You guys call it Apple, right? All that, we were saying the fidelity to, or child protection, was moving into that all of you are strengthening families. So on the social service side, we said, how are we bringing these social service aging programs, right? Aging in place. We didn't have age-friendly, dementia-friendly back then. We do today. But back then, we didn't have that vision, plan. But it was bringing social service together. And then you could imagine, it's that hard line for illustrative purposes was not. This was really now, how we were looking, and we talk about trauma-informed, this was crossing. When we're talking about crossover youth that are in children's mental health and child protection or probation, when you start looking at your high-cost, most vulnerable kids, adults, and seniors, it spans both health and human services and housing. Am I correct? I mean, you know what your frequent utilizers are. It really is. And for us, the same thing. And we were saying, well, wait a minute. We want to better manage, improve their care. Yes, we want to manage cost. But there still wasn't that, how do we bring this together? And then no government alone can do this. No, any one institution around this table could do this alone. We know that. So for ourselves, with the might that we had back then, I mean, we were the largest of our, at that time, we were about $1.8 billion. We were contracting out about $500 million because we believe strongly in public-private partnerships. So we believe strongly about that. We don't believe government should be big government, our philosophy. And I'll show you our outcomes, how we think it's really served us well in San Diego. So how do we fund those neighborhood-based as best we can and other organizations that can render that service much more impactfully? And what are those core services that government needs to continue to do? So that balance was being played out. And for us, our beachhead was a couple of things. One, 2008, and people ask me this question, when you were offered the job, was there 2 steps back by everyone and you just were standing and you got the job? Or, because this was the time when the indicators on the economy was not good, remember 2008? Heck did I know about H1N1 yet, right? We talked about the flu, remember H1N1? And candidly, we were going through a very turbulent time because it was the creative energy about where we're going to go. And our director, Bob Ross, with the California Endowment, left years prior to that, but we were in this kind of idle state. I call it maintenance state in terms of the overall organization. So the question that the board had at that point was, do we go big and really go big and impact, or do we go steady Eddie? And the board said, go big. And I said, great, because I'm not a maintenance guy. Either we go big and we really make the type of big impacts, or choose maintenance, but I wasn't the latter. And I was, as they say in our field, given the day-to-day job You know, you work day to day at the level what we do in government and at all of our jobs. So we immediately looked ourselves, and as I became HC director in May 2008, already you know the national narrative back then was what? Health reform. It was high on the minds of everyone. What we all knew was at the state level and at the federal level, particularly at the federal level, was going to be what? Payment and coverage reform. Delivery reform was quiet. It was going to be left to states and counties and local jurisdictions, and we knew that. And you know, the commissioner is here, and he was, you know, been a champion at the national level for National Association of Counties, and we're extraordinarily fortunate having Commissioner Dulcet there. So preparing and getting us thinking about, well, how are we going to get ready for this change? So I'm Italian. We like to bring everyone together. I don't know any better. My wife smiles, she knows. We get sometimes loud, my family. And I brought my team and said, let's discuss the undiscussables. And discuss the undiscussables was simply, where do we go? And how do we work all together with all the different health-related department heads? And my only requirement was the fidelity has to be a fidelity of one. So in my first year, we went from the 60 logos to one logo, plus one. Aging, our AAA aging, they take a little bit longer to lose their identity, if you know what I mean. Love our seniors and older adults. Don't get this the wrong way, and I'm looking at the camera because I do, but they did not want to forego their identity. It took a couple of years, actually. Today we have one logo. Logos, it's not the logo. It's what stands behind that, the agency of one. I want to be very clear. But what we did was we said, yes, let's create this one identity if we're going to be an agency of one. And what's the one thing? And if you want to do something fun for anyone in public health, particularly public health officer, and they're great, is ask them one thing they have to work on. They can't. They'll give you 101 things. And we went through this rodeo for a while. This was the one thing we landed on. And the commissioners heard me talk a little bit in the past about this. This is 3450. I got to be honest, we didn't create this. We got this from the World Health Organization. It's their defined definition. 3 behaviors that lead to 4 chronic diseases that attribute to over 50% of all deaths in Everett, in your entire state, in San Diego, and throughout the entire country. And in fact, in Mexico, they're experiencing that as well as our friends north of us in Canada. Why this was extremely important is those 4 chronic diseases, as you should know, almost 2/3 to 3/4, depending on what evidence-based research you read, is something that is actionable. It's behavior and environment. 10-15% is access to care, okay? And about 10-15% could be to genetic. And so I've been before an audience in San Diego. I would never sit here. I would always sit where the commissioner is, but actually I have a back door. But to a room full of biotech executives who feel like drug discovery cures everything, and told them, as you well know, that your zip code matters more than your genetic code and your life expectancy and your quality of life. Fact. And in San Diego, like you know, we still have today 10-year life disparity in a child born between the inner city area and more affluent area. Born in the same hospital, living in the same areas, 10 years life expectancy difference. So it's the environment, the social determinants, right? We all know this. But what this did for us is this began our journey about how do we get our electeds to understand. We're not as blessed of having all electeds as a commissioner here and others that spend time as electeds in these meetings and are very well versed and at the national level as well as here. We had to make it, I call it potent simplistic. So how do they understand this formula, and how do they know through policy, evidence-based policy, they can affect and have impact to our work, right? Improving these behaviors to these diseases. So I want to share with you then now that opened our eyes in the mirror about, okay, so if this is about something of a battle cry, our beachhead, knowing we can't do this alone, just even in the Health and Human Service Agency, we're aiming to go over for all the San Diegans. We knew that right? Visionary leadership is seeing what everyone else is seeing, but doing what no one else is doing at the cost of mockery of the present for the betterment of the future. Don't you feel that way in your work? Right? So a lot of mockery and, and all the stuff you deal with the state and my friend Sue and everybody, but all that. And yet you understand and you're doing things that no one else is doing that's improving the well-being of your entire 5 or plus county region. And so that was for us. We started this way and there was a lot of mockery. Well, why government? Why are you leading this? And honestly, I'll tell you that this is the other side. I looked for the hospital association. I looked for the council. I looked for anyone else to lead this but county. Because I thought it'd be best if it was the community and everyone took 3 steps back, never mind 1 step forward. So we said, well, if it's not us, then who? And if it's not now, then when? So we said, fine, we will lead this at the cost of immense mockery. That government fails, why are you doing this? All the motives, everything you could conjure in your mind about why there was fear. However, it started with a small group, and I'm going to show you a chart. It started with one entity that today has grown to hundreds because they took the opportunity to believe and work with us and collaborate. And so this, for us, the mockery was we were moving from sick care, having that discussion in '98 to health, okay? And in 2008 said, you know what? We're going to flip the script. We learned, let me take you back. Remember I mentioned about welfare reform? Okay, TANF? The worst thing we did is that we stigmatized that concept on welfare reform. And so we knew, in having parts of San Diego with a mixed geopolitical, from conservatives to supporters to, about Medicaid expansion, that we had to do something that was going to bring and excite everybody, not just some. And we knew if we talked about health reform, that was going to, what? Stigmatize, well, the social service people, that's about the health people doing this. Or the public safety people, as you're going to hear in a moment, say, oh, that's the health people, they got it. Or the tribal leaders, or the city council, or the county commissioners. And so we said, no, what's the inclusive vision? This is probably a real key takeaway. Your true north. What's the inclusive vision that brings everybody, not some of us? And we defined it as well-being. We said we were not going to stigmatize Obamacare, health reform, whatever. It's going to be about well-being. It's going to be about living well. It's going to be having San Diegans live well. And we defined this shared vision for change and improvement in 3 key pieces. And this is our strategy. This is our playbook. Now, you'll see more in detail. We try to put everything in 1 page. Building better health, living safely, and thriving. And I'm not saying this is easy, because it's daunting just in what we're doing with ACHs, never mind the broader health arena, what we're doing, right? To saying, though, think about it, your number 1 issue is you're dealing with opiates, right, and meth. Well, to deal with that, you have to have safety reform as a dyad approach with health reform. A health reform approach cannot succeed, nor does the safety. We know the safety's failed by itself. So we already said, well, where health meets safety. This is about building better health. It's about living safely. And so we have to do safety reform in a very integrated way. And we can't boil the ocean, so we knew we can't do all that. I mean, we couldn't even get our arms around building better health. We just started with 3 for 50 as our beachhead. We knew we had to grow that. But what we did is we started in 2008 our planning, and then with our community, and presented to our county board of supervisors in July of 2010 our plan for building better health, our health strategy, your version of your ACH plan, but for the region, entire county region. And feels a lot of the same way in what you have here. But we made it clear that we were going to be coming back, that wasn't the end of the definition of living well. That we were going to bring back 2 years later, because it took that 2 years, to work with the sheriff, district attorney, the presiding judge for Superior Court, probation officer, your police chiefs from your cities. But living safely is not just the justice-involved population. Living safely is what? Child protection, adult protection. It's preventing falls of our seniors. It's preventing accidental drownings. It's everybody else that's involved in safety. It's dealing with natural disasters, like snow in Malibu that happened yesterday. Can you imagine? That's like a natural disaster for people in the Los Angeles. They don't know what to do with it. They're staring at it on the ground. They don't know what it is. True story if you want to go read that later. But the mindset was, well, how do we craft this already with the understanding that this journey is going to have to be this 360 of health and safety. And then indeed we came back, our sheriff leading it, great video of him, we can get to you. And, he's walking his dog, Sheriff Bill Gore, great guy, former FBI, sheriff's kind of guy, talking about you can't arrest your way out of the problem. That you have to take, our deputies who were gaining 50 pounds in the first 5 years, that the health and well-being of our deputies, those jailhouse cookies are very dangerous. So he talked about doing right for the culture of his workforce and then thinking about the people that they were serving in the justice-involved population. That's a big piece of what we do at National Association of Counties, that interface, right? We don't call it correctional care coordination. We call it community care coordination, right, between our institutions, right? Be that from the hospital bed to their home bed or the jail bed to their home bed. So how do we change that culture, mindset? So we presented that to the board in July 2012, but that didn't complete us. Because then the third part, the three-legged stool, if you will, was thriving. That came 2 years later. And that came in July of 2014. So to be truthful, we've been in full implementation about 4.5 years of the whole components. From the health side, absolutely, it's been about 10. But why do I say the full? Because we weren't really spinning our impact until we had the full operational. And I don't think we will until we're 10 years from all three. And what is thriving? Thriving is the natural environment, the built environment. It's housing. Now, some of you say, yeah, I learned that. That's Maslow's hierarchy needs. From a different design perspective. It is our action framework. We have approaching, over a $6 billion budget for the county of San Diego. We're at $2.2 billion for just health and human services. After, with all respect to our electeds, after our operational plan, the county budget book, you see the pictures of our electeds, because that's important, because they're our leaders, right? And after their picture, the next thing you see is Live Well San Diego. What we created was the plan. Didn't start off this way, and I'm happy to talk about the Q&A. This was the plan that originally we were going to do for ourselves in Health and Human Services. The county government adopted it for its operational plan. And this is important because you test the Malcolm Baldrige principles. How you spend your time and your money determines how really aligned and effective you are. So if you say this is your plan to the community, are you going to embrace that for your own organization? Or are you going to say, you should do that, I'll do this? Credibility, that whole issue about humility, that we can't do it ourselves, but that we're going to embrace this. And this took years, but this is now in our budget. You'll see this, and including the metrics. And I'll touch a little bit, and we'll do it for Q&A. It was important for us to be clear. I mean, the only thing I remember as a kid from the home economics class, you remember how to teach us how to, we need to bring that back. Kids don't know how to cook these days. I mean, I'm dad, but kids don't know how to cook. Look at my wife. Our kids don't know. But those that remember home economics, they had the food pyramid, right? So all I remembered was the pyramid. But I put the pyramid and created population health in here. And I always remembered the food pyramid. But we said, how do we have one document that has the vision, our 4 strategic approaches about building a better delivery system? Notice it's not a better health delivery system, because where health meets safety and the natural and built environment. Positive choices, we don't believe in taking away people's chunky monkey ice cream. We believe about giving them information and empowering parenting and strengthening families. And not just in our words, in our deeds, in our design, in our policies. 2, obviously, policies, evidence-based policy. Not health in all policies, but well-being in all policies. we were doing a lot of health and all policies, but not thinking about safety. So when trauma informed, and we embraced that for the entire organization, that changed everything. And so we got to think about this in terms of the policymakers, how we look at health and safety from a trauma lens. And then lastly, improving culture from within, which we started with ourselves. We said, if we're gonna make this social movement, well, heck, we have 17,000 employees, and with our family members, that's about 34,000. Let's start there. And then through our deeds, others will see our credibleness, if you will, of really believing and rallying behind. And then what we did from that is that then we said we have to then measurement. It was very important for our board about, I had one elected official in July 2010, we presented this, he said, I need you to come back every year and answer one question, so what? How have you made a difference? A measurable, meaningful difference. And we have maintained that annual reporting on the so what, and it's obviously been extremely significant, from reduction of heart attacks by 22% in our region over 4 years. So colossal chronic disease prevention efforts because of efforts like what we're doing. But we wanted measurement. And I just want to point out, and we won't talk a lot about all these indicators, but you'll see them, you relate to them. The two most important ones is life expectancy and quality of life. And we can argue about, well, how do we measure quality of life? I have some in my mind. It's, what's your quality like? Then we should try to make that as a standard. And we have a far way to go, right? We rank last in terms of all industrialized nations in our life expectancy and quality of life. So we have a kid, we joke a little bit about this, that we want to live longer and happier, not shorter and grumpier. And that's kind of, but if you look at the IOM report in 2013, the shorter lives, poorer health, that is glaring. And that's been a very landmark report for us, because I think what we're trying to do, our communities, is write the sequel, right? Longer, better health, longer lives. So everything in my mind comes and follows through. If we're not improving, and that's how I measure my team, how are we improving life expectancy? Kids in dependency, our severely mentally ill homeless, isolated seniors, our asthmatics and diabetics, so on and on and on. How are we measuring life expectancy and their quality of life? And we know that doesn't happen year to year. This is the long view. And this is why the sustainability becomes challenging, because this takes time. But measurement was really key. And thinking about that in terms of a health equity lens. So we knew that this was going to be about, I call it, for my business, when I talk to the chambers and all the business-minded folks, I call it the healthy bottom line. Because they want to know, is all this work really going to drive any value for them? And I explain it very simplistically to them as, well, until everything is automated, which hasn't happened yet, in a human-centered workforce, a more healthier employee and more engaged employees and more productive employee. No one challenges that. I said, well, to get those, they have to live in places that enable that healthiness, engagement, purposefulness. And so the healthy bottom line is, if you want a healthy economy by which these businesses are driving, you need a healthy workforce. To have a healthy workforce, you need to have a healthy community. And without getting squishy with them with our health equity lens that we all embrace, they kind of get that. And so the little things they do, and I'll talk about examples that they did of engaging the business community, extremely important towards our movement. Things that they did that had little to no cost, but it got them engaged to help their efforts on that. So I'll flick through these. I know you know all this. This is the CDC. Again, the social determinants. We do this, and this is important. Our framework, this is Dr. Frieden, who's done some remarkable work in this time with the CDC, about not just public health, but thinking about this is applicable to all our fields, right? In terms of the health equity lens. And then looking for us with Live Well San Diego, if we're going to improve life expectancy and quality of life, then we started looking at things from age and gender. Yes, the distance of where people live, the zip codes issues, socioeconomic status and race. And so this opened up the conversation. This allowed us, before no one wanted to discuss this because they were, how are you going to address this? How are you going to do this? They'll do a little tiny symbolic gesture of something, but how are you really going to, if you're going to talk about improving life expectancy in your 5 counties, right? You're talking about health equity. And very challenging, difficult, but extremely important conversation to have. And because once you do, and you then are open about where you are, this is San Diego. We're not perfect. We got issues. Yes, we reduced heart disease, but we're not doing well right now in terms of some of our non-communicable diseases, or communicable diseases, excuse me. We're not doing well in terms of some of our socioeconomics, in terms of chronic conditions. We're not doing well in some of our maternal child health. We've reduced black infant mortality, by the way, in our county, one of the best in the last about 15, 18 years, but we still have disparities of kids in child dependency, child welfare. And so by being open about, and behavioral health is a big one, right? We still have the about 20-year life expectancy difference of seriously mentally homeless, which I think is true here in Washington State, I believe. I haven't studied that. I'm seeing nods. So that's glaring, and that's glaring. And then if you want to overlay the costs on that, we know then all of a sudden what's important to us in terms of really talking about life expectancy, quality of life, and then, yes, managing costs. This is the ACH frame that you've been embracing. So for us, Live Well San Diego provides the ability to go after and pursuing these vulnerable adults and kids, using for us the framework for our workforce development, our community, which I'm going to talk about quite a bit, and data, extremely important. And of course, in all of this, and what your collective impact is as well, is, what is that contribution towards that common fidelity on those health equities? And then how do we take a aim frame, not a blame frame? Let's not blame, social services or public health or managed care or the hospital system. That blame frame just deteriorates everything. We have health inequities. We all share in it. So then how do we go achieve it, and how do we measure? And then, I'll illustrate some examples that you could do some remarkable work that, again, you're doing here. So this is just to illustrate purposes of how we do our collective action and collective impact across sectors. We actually put names of organizations in here, and we talk about how they tie to those 5 indicators for Live Well San Diego. And you'll see in a moment, these are organizations that all sectors, this is for illustrative purposes, but they are the ones who we don't have contracts with. They don't have an ACH contract. They don't have an agency county contract. I don't have a contract with the U.S. military, but they all have part of the contribution to this generative kind of mindset of ecosystem. And so how do you get them to work together? And so when you look at this, oh my God, this is the big, but we didn't start with all this. I want you to know, we started with government and some health organizations, right, for building better health, and then we expanded. And that expansion, people worry about, it becomes unruly, you can't do it. For us, our diversity and our strength grew with that expansion. We did not have the opposite effect that some people worry, too big, too unruly, things fall, because then where are you going to have that community huddle? That's all I say. Okay, if it's not you, then where? And so, again, how each of the partners contributes, differentiated but coordinated. So every day we have differentiation of what everyone does. Government's pretty differentiated from a business community and a school, but how do you align the strategies? And that's why you do need a backbone organization to do this type of work. And governance, it becomes extremely important. And we were involved with the IOM, back then at the IOM, now the National Academy of Health and Science, but modeling. And so, I think bringing in and thinking of a steering committee, a governance board, having the backbone support, this is where I think the challenge is how you sustain ACHs after the Medicaid demonstration. We still need this, right? And who supports the backbone efforts? And it's done differently, whether it's government, whether it's whether it's philanthropy, versus private sector. There's been different models in terms of governance, but we all know that if you don't have this table and backbone, you really can't coordinate then that bigger picture of all organization. It doesn't happen. So that evidence is empirical, and I think you know that. This just, we'll go quick on this. This is what I was talking about, the Harvard value curve, about how we're moving. When you're able to bring all these organizations, you can see at the far left, Live Well San Diego. By bringing in all these different organizations, we become much more generative. There's more fresh ideas that we would never have, right? It's kind of like, think about the codathons and the hackathons. Very nerving to kind of do that. By opening up and liberating your data and letting people see it, they come up with ideas and solutions. Well, by bringing in other organizations, they're going to take a look at your challenges to see what can they contribute to, without the mindset of what's in it for me. Here's what's in it for you. You're improving the health and well-being of your community. That has to start with that inclusive vision. If it's what's in it for me, and you start that way, it doesn't lift. It doesn't go. And so I've talked a lot theoretical. Let me give you some concrete. Let me give you some concretes. So I mentioned about the social determinants and how a large part of our work is try to go more upstream, try to go as much prevention. And the truth is, we think about the continuum of care, right? And I didn't include this one chart, but we actually measure the amount of money we spend downstream versus mid versus upstream. Where do you think we spend most of our money? Downstream. Okay? How much, to me, in San Diego, a full-service partnership for a seriously mentally ill, if we can get him or her engaged and get them housed, is about $30,000, $35,000 a year. Pretty much probably for their life. But in our in-home support, a fraction of the cost of dealing with people that are beginning to have some symptoms and working with their family to get them stabilized is a fraction of the cost and is far more upstream than letting them deteriorate and ending up on the street. So we look at this model and this lens, and this becomes really real. We look at this from child welfare. The amount of money and trauma we do for kids that come into dependency have a huge health impact to those lives because of the ACEs and the trauma scores. But if we're seeing families in crisis, why aren't we intervening where appropriate when there's no, obviously, harm to that child, but crisis you're seeing with the family, to upload those services that we're only going to be required to do once they come into our system, that counties are going to be required to do, i.e. taxpayers are going to have to pay because the court orders it. Again, this whole mindset, even for our child welfare system, we're going through a big change now, saying it's no longer child protection services, it's family strengthening. And changing the whole system of child welfare, because it's aligned to a much more balanced, you will always have situations of downstream with all the great might of our efforts. But we can do far more improvement by going upstream, taking a wellness lens, right? So this is where we are today in our ecosystem. If you remember that slide I had, we were kind of like, we were which way but loose when we started in 1998, and then we started balancing the health stuff and the human service stuff. Today, you can't see that. It's blurred. It's this. Hub and spoke. Hub and spoke. Because no one entity really has the solution, but collectively, we have greater vision and impact. And for us, this is a, oops, sorry about that. It's really important for us that we had this, not just government. Yes, we started this. Yes, we no longer own it. We had to liberate it years ago by the community, because you'll see in a moment where it wasn't owned by the government. It was never intended to be owned by the government. And in fact, if it's owned by the government, it could be, I think, problematic because of trust and everything else. But if government helps spur it, and then the community takes it, and government stays engaged as an invested partner and supporter and enabler, then you start getting community saying, we want to do this. So I'll give you an example. I have a community citizens, regular citizens. With our funding, if you remember our funding, stimulus funding, one of the first things we did is we spent some of that money, because it was supposed to be jobs, workforce development. We said, what better way than to develop community residents as leaders and have them understand what's happening in their community, be it public health, be it community design, be it converting empty yards into community gardens, be it running for office. I mean, not pushing any political ideology, maybe just understanding the process. And so today we have over 50 different we have an alumni group of hundreds of these folks. Some of them who became our first African-American mayor in Lemon Grove, who came through Resident Leadership Academy, leading Live Well efforts in her city because she became part of this 6, 7 years ago. So it's about the community. It's about the community. And remember earlier I mentioned that when we started this, Mockery Lane, any football fans here? Any Charger fans? Any Seattle Seahawk fans? I know. I'm a Seahawk fan while I'm here. And I don't have a team, so I could be a Seahawk fan. I don't have a team anymore. I'm an orphan, that's right. So, but we had a serious situation. Junior Seau, a legend in San Diego for those play in the watch football, track football. He's deceased. He was a linebacker, a Hall of Famer, and he committed suicide. And which is very tragic. Brain and all the things side point here. But he's in Oceanside, the northern part of our city. And he was tremendous for the Samoan community, him being Samoan for himself. And they had a lot of issues, Samoan communities, with obesity and diabetes. And so the city of Oceanside, who, as a city, now I'll look at the commissioner, cities and counties have interesting relationships. Sometimes they love each other, sometimes they hate each other, sometimes they fight each other. You know, it's just like families, right? And they were fighting over some rail that was going through the city, through the county. Hey, wasn't Health and Human Services. But the city and county weren't getting along because of some rail that was going through the city. So the city was trying to railroad it through the county. That's correct. There you go. Any here from the city? Want to counter that? But yes, and so bad juju, and you know, and so, but Mayor Wood, no longer in office now, retired, but he saw what the county was presenting. At that time, we just released in 2010 the first part of Live Well San Diego. And we, as I mentioned, this plan was for us initially. It wasn't to be telling others what to do. It was informing the county how we were going to work together with our own employees and programs. And the city reached out and said, we want to join you. Now, we had no membership. We had no design of this with Live Well. We have now. But back then, we didn't know what to do with that. So, of course, I went to my commissioner and said, the city, who you don't get along with, wants to present this proclamation to join. And, they weren't happy with it, but what are you going to say? You can't say no to an elected. They said, well, just go. And, but Junior Seau, we were presented to be in city council, and literally took his life days before the city council meeting. It was devastating for that community, for the county, never mind the city. And I said, well, for sure they're going to postpone or not hold the meeting. And Mayor Wood reached out and said, no, we're going to go forward with it. And I was stunned because I was like, well, gosh, national news were there and local news. He said, because it would matter for Junior Seau. What we're going to do is improving the lives of the kids primarily. And I remember going with a couple of my staff, and it was really very depressing because there was just a lot of the fans were there because they were going to get an update at the council meeting. But they presented the proclamation, and the way he presented was just that we're going to make a difference. And so it opened my mind to saying, wow, this is a city. And what he talked about, the mayor, was, I don't have a health department. In the county health department runs for the cities. He said, but we have what? Parks and recreation. We have libraries. We have our law enforcement. We can clean up the parks. We can be a contributor with the county to really have actionable impact on making it more livable and getting families more engaged. And that one was our first Live Well partner. To this day, officially, we never officially, we took his proclamation. We didn't give him one saying you're in, but he joined us. And that then began the journey. That word got out of, okay, this is about how do we, no contract, there was no money, and to this day, I call it the public handshake. Our commissioners, supervisors, they do a proclamation honoring that organization, and all they have to do is talk about what are they going to contribute, be it on the health side, the safety side, or the thriving side. And they have to re-up every year, voluntary, and we have to measure that. And today, we have 428 organizations. And let me tell you, one organization is the San Diego Chamber of Commerce. It's the largest chamber of commerce on the entire western region of the country. They have 3,000 businesses. mainly small. They're considered one of the 28. So you could see school districts. We have 37 of our 42 school districts that became Live Well schools. I'll illustrate what does that mean. We have almost all of our incorporated cities. We have 2 outliers. We have a couple of hospitals who didn't join. And that's when you know it's real. Because if everyone joins, it's either something wrong, right? Either there's a monopoly or you're doing something. There must be some rebates or something, or I don't know. But when you know some people still are weary of it, and we do, it's causing some friction for folks. But overwhelmingly, you could see we've had a lot of people that join. And frankly, I know you don't know a lot of these logos, but you probably know the WD-40. Anyone know what that is? The lubricant? Yeah. And so when Gary Wells, we had my supervisor, Ron Roberts, we went to he's in San Diego. That's where their corporate is. And 250 employees. And you're thinking, what does the lubricant company have to do with, Live Well? And so I thought, it's important to brand things. So we're right there. He brought his employees together. It was just only a couple, about 20 of them who are working in employee wellness. And I said, Gary, this is great. You're coming as a Live Well partner, a business partner. I think your logo should go, lube well to live well. At which point he said, no, that's the other company. That's not our company. And Brett, a little comic relief there. But the point is, he became, because he wanted to learn from other businesses about worksite wellness. Imagine that for a moment. It went further. And his employees wanted to work with the schools where their employees lived to get involved with their schools of volunteering. And WD-40 being a very reputable organization, business, helping get others aware of that. So this is the movement. It wasn't us telling Gary or WD-40 to do this. He heard because I was giving a talk at a community board meeting at a San Diego Foundation, and he's a board member, and he heard it and reached out. So everything about this is organic. Everything about it. We did not want initially to have any strong guardrails other than it had to drive wellness. So we've had a couple of tobacco companies that say, we said, no, it doesn't fit, sorry, with us. But majority of smoke shops, they were primarily, do. And these businesses like Vons is a big shopping center. What did they do? They said, look, how can we help? We said, well, what are you interested in? They said, well, we love maternal child health. We said, well, could you label your aisles baby-friendly foods? Because they have 26 shops. And our moms, and particularly some of the moms who we don't have the full education, we said, wouldn't it be wonderful they just see at least the baby-friendly labels to know what's good for her and her child? And so that's what they did. So this was the whole issue about everyone can contribute, but they had the vision. They had the Live Well vision. They saw how this came together. Prior to that, they weren't doing this. Or they were doing kind of what you call the tiny symbolic gestures, but it wasn't organized and developed together.
I just had a question because our insurance companies, mainly Medicaid, are really involved here, clearly, because all 5 of us are sitting across from you. But,
Yeah.
and I only see the 2 of them on here. So do you have the other ones involved?
We have all our plans as Live Well partners. I think, let's see, I don't know, we have 7, we are geographic, we have 920,000 people on Medicaid in San Diego, and we have 7 plans, right? We couldn't fit all the logos, this is illustrative purposes. But I think Aetna hasn't, we haven't done Aetna yet, I think, and United, I think is, but we have all others with us. Yeah. So just real quick, non-traditional partnerships are the key to improving health and well-being. Non-traditional partnerships. So cities, safety, this is the issue about the diverse aspects. So if you were to develop your slides, how would your logos illustrate a purpose? How would that look like? And would you see predominantly health, or would you see a diversity of an ecosystem where you are driving the health, but the others are enabling that? I don't know, but that is something to consider and something we can talk about. We have an advance, so 3 years ago, our partners were saying, we want to learn together. We want to have this kind of collaborative learning. And I probably can't accommodate all of you, but if there's a few of you, be happy to host you down in San Diego. We have terrible weather down there, but you're welcome to come anyway. It's in October. We have an advance. Last year, our first year, we brought in 750 people. The second year was about 1,000 people. This past one, just been a third one, 1,300 people. This is our town hall. We have a full day, and it's called the Live Well Advance because we don't retreat. We advance our well-being. It's really important. My management, we don't talk retreat. I never do any retreats. I'm not a military guy, but I'm just wired of everything we should do. You're advancing your vision, learning, and I'm going to be learning from you. So we're advancing. Everything is advancing. So this Live Well Advance, we bring keynote speakers, but you know what it is? Our partners learning and talking with each other. Enabling the behavior, bringing people together and learning. Do all 400 and some odd come? No. We usually get about 3/4. There's some that just, ill, don't come, etc. But the issue is, how do we then create this kind of collaborative learning environment that excites people? We charge no one anything for this. This is completely financed by the county and our local foundation who join in on this, San Diego Foundation, Alliance Healthcare Foundation. So real quick, because I want to make sure we go to time. Signature event. So my birthday is on Valentine's Day, and so 8 years ago we said, we had a supervisor, he said, how are we going to effectuate 3 for 50? And we said, well, heart disease, leading cause, in terms of, for San Diego was one of the leading causes, now it's the second leading cause, because we effectuated heart disease and stroke, including for a stroke for African-American men. We said, we got to do a couple things. We have to have a university of best practice. We need to make sure, can you imagine, cardiologists have a heart, can they all come together, and can they get together and standardize clinical practice? White coats only, no administrators, get out, white coats only, and they do. And they have got together, and they are ACH in San Diego, and part of it's called Be There, worked hard on this, and remarkable things did. Started first by sharing the data that their administrators said, well, I'm being taped, data that they were told they really, shouldn't share. And they went under the tent only, and they had their moments of wow, okay? And that self-discovery led these cardiologists, including my public health officer, my chief medical officer, again, white coats only, and nurses, because I think I'm a big fan of nurses, but they came in and they came up with an approach to looking at how we standardize clinical practice. Now, here's one. This is a no-brainer. Let's make sure everyone takes their what? Blood pressure. To me, it was astonishing that we weren't doing that until I looked into my own public health and realized, oh my, we weren't doing that. And so I went on this vengeance. Okay, if that's the thing we could effectuate, right? Getting people to take their blood pressure, because that's what? Actionable. We know what? Half of adults are elevated blood pressure. Over half. So how do we effectuate that? Well, standardize. Let's make sure everyone takes their blood pressure. I worked on my dentist. My wife and I, as a dentist, great guy. I've been with him for 20 years. And in the last 5 years, he just got tired of me. And now even my dentist does what? Blood pressure. And why he didn't want to do it initially? If you're watching Dr. Joe, it's because he didn't want to know. Because if he then knew, then you have to do what? There's liability. You have to. But I said to him, well, why would you want to do a medical procedure if you didn't know, what's going on? And in fact, he was doing blood pressure only for the severe kind of surgeries, but for all the patients. Now he does it for all the patients, routine coming in. We haven't, again, that's a private dentist. We're trying to get that to all the private dentists. But back to Valentine's Day. 7 years ago, we said, let's do something. Let's create a collective movement using Live Well, all our partners. What if we were audacious to say we were trying to get the entire county to get its blood pressure? Adults, obviously. Now we're thinking about kids, but back then it was all adults. And of course, we said, what a great battle cry. 3 for 50. And in fact, what started with our own offices, and we had Kaiser Permanente and Anthem who helped with us. and some of our public health clinics. Fast forward, year after year, we started adding our different non-traditional partners. Who is still widely misunderstood but wants to be loved? Fire departments. No one visits them. Liz is laughing, she knows. No one visits them. They want to be loved. You go visit a fire department, they're excited to see you. Why? Because that's the last place you want to go visit. You get the bells, the whistles, etc. So we went to the fire department chiefs and said, listen, we have a way you can get loved. What if you, when you're not, taking care and saving lives in the fire, do blood pressure? They're all trained, as you know, as first responders. They said, absolutely. So what did we do? Our rural fire departments in the rural areas, inner cities, they opened up shop. Libraries, businesses, universities. All of a sudden, there were others that said, wait a minute, we want to do this. So in our last recent Love Your Heart, this past Valentine's, we had 240 locations countywide. Rural, urban, all free. Now, in the retail pharmacy, you can do it free anytime. But it was raising the consciousness of people doing what? Knowing the importance of taking their blood pressure and then taking action on it. Over the last 4 or 5 years, we averaged about 100 people that were rushed to the emergency room that didn't know they were that severe. Real lives saved. Our local ABC 10 News has become a Live Well partner. No cost. Cover events like this. Anchors, broadcasting it, no cost. Where's your local news? Joining you to elevate and lifting your message. Mockery Lane, right? Because they may be doing a piece on any one of you that same evening. They do for us, but how are they part of this effort? 6 northern states of Mexico joined us years ago. Viva Ben Mexico, Live Well Mexico. They do blood pressure screenings. We added other states and localities. Even New Bedford, Massachusetts, my wife's from the Beg, even New Bedford, Massachusetts does Love Your Heart event the same day. We'd love to have you guys join in that too, movement, or what version you do of that. This is the collective impact of population health. Now I said that we just had a study from RAND. Yeah, we reduced heart attacks by 22%, but 18% better than the rest of the state of California. This did not come from more stents or meds. This came from the collective of everything we've been doing since 2011. This is real. Measurable in millions of dollars of savings in Medicaid and Medicare. And commercial. So Love Your Heart for us is more than just, and this is the B there, and this is the heart attack, 14 better than the state, again, 22% total reduction. Happy to give you that material if you don't have it. Comes from work like you're doing here. But it has to be multi-sector to achieve that aim. You know where the greatest traction we had? On Sunday sermons in the faith community. We did blood pressure this past weekend and on Valentine's Day. Why? Faith community started preaching the gospel of health and well-being. Extremely important. As I said to one pastor, if you care about your congregation showing up, you better care about their health and well-being beyond their spiritual well-being. Live Well San Diego embraces spiritual well-being, and that's why the faith community grabbed it. That's why Native American Indian nations grabbed it as well, because they could see that's holistic. And as a government, we can talk about spiritual well-being. So I'm going to be out of time, I think, Liz, but this is our work around with the Clinton Foundation. We've been doing several years around disproportionality, health equities, and equities of kids and child welfare. Took the same page of Live Well, brought 42 different organizations and beyond, worked on system improvements for kids in foster care and probation, particularly focusing on children of Native American Indian and African American, which had the greatest amount of disproportionality. Government couldn't do it by itself. And this is really changing our whole mindset about how do we go more upstream in strengthening families. To our work in schools. Our more southern region of our county is Chula Vista, lower socioeconomic, primarily Hispanic. In 2010, they had more kids missing school. And the superintendent, again, one of the early adopters, said, this thing in Live Well, you think we could do something? And we said, we're not sure, but we said we have to look at the data. And can you imagine, we had at that time 25,000 kids. It's the second largest school district in California. What do you think the abnormal BMI was for the 25,000 kids? We had a 98% or better approval rate of parent consent. Remember, 2010, there was a lot of against height and weight because of the stigma. This, that's another story in and of itself. How do you win the hearts and minds of the parents? Building public trust. But what do you think the abnormal BMI was in 2010 for these 25,000 kids? 40%. Overweight or obese. Some grade level, 60%. We know that it's about a 75% chance that they're going to have diabetes by the time they're 18 if there was no affect. We would have to be adding dialysis machines, never mind fast food vending machines in schools at the rate we were going. So this one school, large school district, superintendent, the board, we said, we got to be data informed. Let's bring in our partners. We brought in the cities to help to clean up and make the park safe routes to school. We had mutiny in the school because we took away the cheesy nachos to a book drive. We added more healthy foods. I didn't visit the school for a year. They didn't like the public health people. But here's the thing. We measured where they lived. We used the power of public health. This is where public health becomes very important, your epi. How do you look at where the kids lived? Because we know what? Place matters. And so we wanted to see the correlation to where we were making improvements to where kids lived. And I'll bring that thing back. So that's up in the far corner, 2010. Red is bad, blue is good. You could see orange and red and yellow, bad areas. These were bad in the sense of that this is the greater concentration where the kids lived in that school in Chula Vista. And so you could see over time, now far bottom right, there's no red. We changed. We removed all kids that were severe out of severity. We had kids overweight, but we reduced it. Reduced it to the amount of almost 18%. What the superintendent said in a matter of 6 years, said it would be enough kids to fill up an entire elementary school or two. How did this happen? This happened because of organizations like ours in the community with the school, kids then informing their parents about healthy eating. We have videos and testimonials of this, right? The teachers. And so what did we do? Scope and scale. Everything hub and spoke, scope and scale. So we learned from here, okay, great. How do we have a toolkit? We did this, we learned about how do we win the hearts and minds on the BMI surveillance kit, then share that with the other schools. Then we took the best practices, evidence-based, we created tools for schools for the kids, and took that for the 42 elementary school districts that have 650,000 school-age kids in San Diego. And said to the superintendents, all in the room, which of you want to do the next video like Superintendent Escobedo that talked about how he improved the health and well-being of kids first, improved the educational performance second, and third, their school funding, because a kid that's absent is money that the school loses. Some of it sounds like a little bit like the triple aim for schools. So what we do, I keep coming back to this, what this body does is creates this kind of thought leadership and scope and scales it. That's really making a difference. And your chronic disease for us in this case was kids. Resident leadership, I'll just tell you, this is how we engage community, because I want to get to time, and you can see the efforts. There's a lot we do in the training with residents. We said early on from Live Well San Diego, no offense, it can't be about the professionals. It also has to be about the public. It has to be about citizens that are engaged. So I would say, where is your table of citizens? Yes, your citizens, but non-professionals that are having this equal supporting conversations and efforts like you, supporting you. And so that's our effort with Resident Leadership Academy. We have now called Live Well Communities, we've done hot spotting. Because we've been at it long enough, now we're looking at like places like Chula Vista, the school district. We're going into communities and using the promise zones, or the promise neighborhoods, if you're familiar with that granting, and calling it Live Well Communities, using local money only, but to leverage that with other funding to support and to accelerate now cross-sector work in neighborhoods that still have high acuity needs in terms of disproportionality. So being smart, using kind of doing the Brenner's work, but for population-based kind of in our work in the county. And again, it's all about not just consulting. We do consult. We engage and collaborate with community. And there's a lot on this area that we could talk about in terms of the work that embraces. And one that's amazing is the 30 women leadership group in Chula Vista, separate from the school, and they started what's called Neighbor Day. And Neighbor Day, we bring the mayor, et cetera. You know what Neighbor Day is? This was a community that was fearful of what? ICE, law enforcement. This is the whole thing about primarily Hispanic community, fearful of law enforcement. And Neighbor Day was, how do we restore civility? Key aspect of Livewell San Diego. How do we restore civility? So what they do, these moms and their kids, school-age kids, is they make pancakes for the law enforcement, for first responders, fire and police, which is amazing to see, modeling for their kids. And then after that morning, they make these Mexican paper flowers. And I don't have pictures, I should have, but then they go in their community, the people they don't know, to knock, to get them to meet their neighbor. Bringing and restoring the issue of neighbors, trust, connectivity. That's a Livewell resident leadership, but we don't do it. They manage all that. So how do you create your brigade of these resident leadership? Housing is health. We do a lot on that. That could be a whole separate discussion of itself, but we see as housing is not bricks and mortar. We see it as health. And we have programmed it in that way. And here's an interesting exercise if you haven't done the inventory across all your programs, everyone that's doing housing. And do you have a collated and integrated plan of all your different housing matrix? Because it's pretty remarkable when you see that and how you leverage and optimize those resources in a way that helps you, because no housing, you can't achieve the aims of a lot of your work. We can't achieve it even we don't have enough adequacy of housing. So how do you maximize your housing resources? ConnectWell is just to let you know, we have a health information exchange. We said if we have that with all our hospitals, we were one of the beacon sites. I'm not sure if Seattle was one of those back when we had the HITECH Act, but San Diego was. We said years ago, well, if we could do that for hospitals, how do we connect all our county programs? How do we connect? And this is a work that the Commissioner Dowsett and I have been working hard on, the interoperability, but how do you connect your probation systems, your child welfare, behavioral health, Medicaid, all those systems? We did. And we got this tool, and it wasn't a policy development tool. This was a tool for our line staff. And now we're rolling this out to our contractors. If we're going to talk about person-centered, well, if you're a worker, you need to see that person-centered with their permissions. And I have to be careful. My wife is a lawyer, and she was part of this on that confidentiality. It was giving birth to a porcupine to get through it, but we finally did. And the point is this: it's gnarly, and we're still dealing with CFR 42, and there's still things about but we're working through that. But we have a system where it's permissible. And if you come to one of our offices, to our Livewell Center, you can go over the shoulder of any one of our workers, and they could pull up the record with of someone they're working on, a family they're working on that's cross programs. And now we're rolling this out with our community contractors. So this is the RIO, the Regional Health Information Exchange. We've had to fund it ourselves. We didn't use any 90-10 funding for a whole other story, but extremely important in our work. It's the digital backbone for Livewell. So leadership, culture, I'm going to go through this. This is kind of our branding. We even put the dog, Poe, so we have a mascot. We talk about the diversity, whether you're a probation officer or a nurse. We elevate and lift the personal stories of how people are, how they're living well and how they're helping others live well. It creates that whole movement from within. That's how you have to nurture. And how are you going to nurture social movement? You have to nurture also your own individual workforces if they're going to work extra hard, including with the community. So the great Irish philosopher Bono from U2, right? He said, the biggest scale you can get requires the simplest idea, and that's by connecting with people. It gets back to culture and relationships and partnerships. So yes, we know we're moving towards a whole person wellness. That's what you're doing here. That's your ACH. But this whole concept for us, for San Diego, is we really informed our work from welfare reform and our business model of a fully integrated health system to then being more person-centered and a more population person-centered effort, a well-being. And I guess in Q&A, time permitting, we've had lots of lessons learned. And one of the big challenges, clearly was that we didn't want to have the start and stop, start and stop. You know, the initiatives we've all been part of. So we designed Live Well San Diego with the prospect that we did not want this to be a membership dues or, no offense, tied to the state and contended on. We had to jumpstart it and support it so it was going to be sustained, that it is something that the community wants and needs and wants to be part of it, not because they have to be part of it or because it's there after a grant. Because grants start and end. Relationships continue. So lots of work in terms of equity, and I didn't want to miscite that, you know, we jokingly talked about the climate, but climate change and how that's impacting our work and the workforce development and the multi-generational points of the workforce. Our work is highly complex as we look from the equity lens, and it's multifaceted. And that's why for me, as the Health and Human Services, I need help from so many other entities to be able to really address equity around life expectancy and well-being and quality of life. These are just, because you'll get the slides, I wanted to make sure you had some of our websites where you can get the data. So we really liberated data. We took Socrata, and you can get all of our work from public health, including our Live Well work for our partners, so everyone can see it. So it can be informing of what's working, what's not. And that was a big game changer for us, of liberating the data and truly making it transparent. And I got to tell you, we haven't been slammed by the media of why it's failing, because they see, and in fact, I'm going to jinx myself, I hope not, but in the 10 years of doing this, and you know Mockery Lane, we haven't had a single, not a single, negative or critical article from the papers on Live Well. Not a single. And it's due, I'm sure, but we haven't, right? I know. But it's been positive, and I think it's why. Well, what is a reporter or an editorial board going to say? Shame on you in achieving wellness for all? That's the beauty of this. Everyone's tied in it, right? And so the takeaways for me is, I think, pretty, you know, self-explanatory. You're doing this, right? The 5 E's, you know, of engagement, you know, all the way from engagement and enlistment to empowerment, right, to evaluation. You know, how you look at neighborhoods, from the engagement to the execution and evaluation, is extremely important. And that's involving them then. To how you keep it simple. I talk about potent simplicity. You know, 3 for 50, the Live Well action framework, that one document that we can, in a matter of, you know, half hour, go over and help people understand at that level without the data. Making sure it's evidence-based as best we can. We talk about how do we harmonize the galactic amount of data that we deal with to humanize action. Because whether the electeds need it, we all need it, to talk about how this is working. How do we humanize, and you have so much of that, and how does the media help us and others lift up that humanization of what we're doing and the success and impacts we're having. And then keeping it moving, and the flexibility, right? You're going to learn and adapt, and that's what I appreciate that you're doing here. You're bringing other people, and you're getting perspectives, and I think that's terrific. And that's what we try to do in San Diego as well, in our journey. And lastly, you know, Mockery Lane, right? And hopefully you're a lot less on Mockery Lane, but you got to keep it upbeat. It's hard. This is hard work. A lot of, you know, demands on your amazing staff, but all of you as volunteers on the board. You have to keep it upbeat. And I don't know how you celebrate, but we celebrate. We try to celebrate meaningfully, because I think it's important that we do that. We don't do enough of that, for sure. So I had a slide which was Live Well, North Sound, ACH, but you know, just so you know, this is our waterfront park. But this was our journey, and I probably went over. I apologize, Liz, but I wanted to give you the kind of, hopefully you could see, we have a lot still more unknowns, and don't take this as, you know, we've had some big wins. Yeah, we're proud of the accomplishments. We feel we're in our infancy of our social movement, in our infancy, maybe embryonic level, because there's so much to be developed, and we got ourselves in this rut in terms of the life expectancy and everything else, and the system that we have to deal with over decades and decades. It's not going to happen, you know, overnight. It's going to take time. So the last thing I'll say is, who's the successors? We've talked now more about who's our successors. Who are we talking about? Too deep, not one deep. Too deep. because that's what it's going to mean. And you know it's so disruptive when you lose leaders. I got mine. I got my succession plan. It's important. We have to have our succession plan, from our electeds to our leaders to our non-elected community leaders in there. So that's our story. Thank you for just great attention you provided me. And Liz, I'd turn to you or the commissioner.
And I don't know if you can tell the story without the other picture, but would you share just like what this picture is? Would you tell this story
Oh.
about kind of how this came to be?
So this is an actual, it's not as clear, but this is an actual picture of families and kids celebrating on our county waterfront park. And what you won't see to it is in the middle of this park is our county administration complex. About 5 years ago, it was asphalt to the north and to the south, this big asphalt where the employees parked and the public parked. And you had the county building, historic building. It was built in the 30s. And so it wasn't just Live Well, it was our elected board said, you know, we want to make sure we celebrate our work. The people, again, like, you know, you want to be loved, you know, like the fire stations. We want to make sure people come and use this and celebrate it and not fear it or look at it as an eyesore. And so the board, the board of supervisors said, we need to make this a useful utility for all, not just what happens inside the building. And they made this bona fide waterfront park. And over the summer, we'll get literally thousands of kids over the summer. We have the north and the south, and it's a waterfront park. There's recreational stuff for the kids, huge lawns, a lot of civic events and protests. You know, but it's, you know, it's now being used that way. And so the joke is, you know, sometimes it feels like a circus on the outside, and it prepares you sometimes for the circus that's in the inside, right? And so it feels good either way. But yeah, this is a transformation, and it's maybe a reminder about how we have to transform ourselves. And it's not just government, but all of what we do.
Thank you so much. I told Connor I was going to take my hands for the first question, but I may give you a break. And as commissioners also, since you've been mentioned so explicitly in the presentation,
All admiration, too, I will say that.
you might want to jumpstart us.
Well, first of all, okay, yeah. First of all, I want to thank Nick for being here. When I saw he was going to be here and speak, I was really excited because he's so dynamic as a leader at NACO, and he leads our health steering committee, and he's innovative in a lot of things. One of the things you didn't talk about was the big Hep C outbreak you had, and that was something that you had very dynamic approach. Here in our state, we're having a measles outbreak in certain areas, and so I thought it was just tremendous how you would approach that. And I don't know if you could give a little blip in a hurry on that, but it's really great having him here, and I hope that people can go on, like from the counties that are members of NACO, we can access a lot of the information because San Diego has made it, you know, available. And his weather's not really that nice. I was down there in December. For a retreat, and we had a flood alert. You know, so when I left Skagit County, where we do have floods all the time, I thought that was a surprise.
Well, thank you, Commissioner. The admiration is absolutely mutual about your leadership. And, you know, and by the way, you know, for us, deep to our Native American Indian roots in San Diego, rain bestows good luck. So you should know that for us. Just real quick on hepatitis C. You know, we didn't learn from the 1800s that poor sanitation leads to horrendous situations. And when people are, because of places like ours that don't have enough housing, you're going to lead to things like outbreaks like we saw in New York City in the 1800s of cholera and hepatitis. And so sure enough, for us in 2017, we had just an unexpected outbreak of hepatitis A, and this was severe. We had over 500 hospitalizations. We have lost 20 lives. We were projected to have and we still think it's, you know, the lives of 20. Primarily, they were homeless with highly vulnerable individuals. what the commissioner's talking about is what we do, be it public health, county, any one of us. We immediately mobilized. And as soon as it was detected in March, for us, there was no thought about mobilizing the hepatitis A vaccinations. And literally within days, we went and began the vaccinations of what we knew, where we thought the population was, which ended up being the severe homeless and serious mentally homeless and the injection drug use, substance use disorder population. And then the third that we did pursue was men who had sex with men population and food handlers of that population of helping those folks and first responders. And so when you have that crisis, you have each other, and sometimes there was no playbook because this was the first outbreak post-vaccine era. And so CDC, we immediately reached out to our state CDC, and they said, well, you guys have to, get out there and try to vaccinate. And so what we developed were called foot teams. We immediately mobilized our public health nurses. We worked with our managed care plans. We worked with, obviously, our cities. We worked with our homeless service providers, trying to find out where folks were. And if you can know, and how we deal with people with serious mental illness, we were not going to take a penal approach. So this was a population that typically was resistant, even some severely, to being housed. Imagine, now you're going to have to say, by the way, we want to have to give you a shot. Thank God for public health nurses. They are the angels, because they, in some cases, had to have multiple, and I mean a dozen, engagements with person over time to convince them that we're not harming them, but helping them. And so we did was approaching 200,000, 150,000 vaccinations in a matter of 9 months. And I will tell you, it was not easy because there was panic, and so we had to maintain the panic. This is when there was a major hurricane in San Juan, and so the vaccine supply was then taking a drop. There was this worry that the worried well were going to rush in, and media was not kind to our work. And we had to stay focused. We knew we had to, even though with this great scrutiny and the concern people had of we weren't doing enough, and we knew laser-like focus, we had to get folks vaccinated. So we did this whole saturated approach, targeted using data, getting to streets, getting to ravines, the unincorporated areas, and then working with the cities to sanitize their streets. So what we developed, our playbook, ended up being vaccination, sanitation, education. And yes, in a matter of literally 9 months, what the projections working with our local university, medical school, was had we not taken the actions we've taken as accelerated, we were expected to have triple, quadruple the number of deaths and those infected. And one hospitalization is about $6,000 to $12,000, just one hospitalization, and they're pretty severe in terms of the recovery. So we wish we didn't have anybody that fell ill, and clearly the 20 lives lost. But had we not, I think this is where the public later on is appreciative of the work that we do. And we've since then have helped Detroit and other jurisdictions, Indiana and others who are still experiencing their hepatitis A outbreak. But it's a matter of, Commissioner, it's not a matter of if, it's just a matter of when. We have shigellosis right now that LA has, and it's, and so we're dealing with that, or, the issue of measles, we've had measles outbreaks. And so our vigilant work, and this is why it comes back to ACH, and why you have to have this strong network and broader. Because when you have clearly a crisis, that's also when people come together. And so how do you use that then, and then maintain that energy when you're dealing with a measles outbreak to then focus on, opiate epidemic and heart disease and diabetes and the other issues that you're taking on.
I just want you to know, too, I do actually listen to you when you make these presentations.
So I would actually appreciate you going into more of the experience that you all had in San Diego after the Disney measles outbreak that actually led to California legislation around
Yeah.
immunizations. We've had a series of bills being proposed in our state that have been unsuccessful. There are more up this year, but we have over 60. I haven't seen. Yeah, it's approaching 70. The number changes every day. Like, it's a very serious problem, and we have a very vocal community of concerned citizens.
Yes. We do too. You know, and we have to, we'll agree to disagree, but we have to respect. Now it's different for us, but back then we had to respect the wishes of the parents. So you saw the slide I had about, for the triangle about positive choices. And for us, we were not going to be penal. So where we spent our time, and this is where it's extraordinarily helpful having resident leadership and other faith-based and other, I'll just say, community groups, because they're the ones who helped us immensely in carrying that message. We held, like I'm sure you're doing, community forums, but we weren't managing them. We were invited. It was the community holding them to help educate. It wasn't just the other concerned parents, it was also the spillover effect that was having to other families and parents. So we were concerned that this small but vocal voice could influence other parents. So we provided the facts, the evidence, but we had to do it with our community. And I think, you know, that really helped us, because that provided us enough of that herd immunity that allowed us to get a handle on our outbreak on it. But we had clusters. And so hot spotting, you know, you have your clusters. So we kind of knew where the clusters work, and then worked around within the school, within, at that time, the limits we had between the state law, and with our community partners. I can't say enough about the importance of how that helped. Had we not had those partners, I think we would have had a longer lag in terms of the measles outbreak for us, much longer on it. So our public health officer would say, one, it was those partnerships and the conversations, the honest but difficult conversations, right? But also you have to be really careful here about our knowledge and providing for schools, and don't ever underestimate how school-age children can help bring information back to parents, from eating to dealing with things like obesity and sugary products, to thinking about getting flu shots. Because remember, what kills more people than measles is the flu. So we were already taking the frame, faith community, schools, nonprofits, that every year we work with in terms of our influenza campaign. We just kind of mobilized those same entities around for measles. That's really been that was our approach. Yes.
I'm curious about when you were talking about all the different entities sharing records back and forth. How did you get over privacy policies? How did that work? Because we're kind of doing that in my organization right now, and we're not sure how.
So starting first from within, so from within my own agency about sharing, right? And I got to say, again, remember my conversation about fidelity to the profession, fidelity to the cause. So in my own organization, I had to bring a meeting of the minds, because I am the authority for my organization. But I had the epi person saying she owned the epi data. I had the child welfare person that she owns the child welfare data, behavioral health. They all, and I said, none of them own the data. Because they don't. I said, I don't own the data. I am the steward of the data for the board, and the board doesn't own the data. It's the public. So we culturally had to get the mindset of, you don't own the data. And I had to be a little dictatorial. I had to be a data dictator to say the fidelity has to be us sharing it. That was important because they were also the subject matter experts on those data sources to know what the privacy were. The attorneys come in, but they're relying on the experts of what are the requirements that they each have. And that took us years to go through that inside the Health and Human Service Agency. And we had to get through the issues about consent. And so we've been fortunate that we stuck it through, but I got to tell you, this was one of my big driving priorities, because I know without the data, here's what I said, today, back then, not today, was trapped. You couldn't achieve interoperability. But I wasn't interested in interoperability. I was interested in interoptability. What's that? It's once you and I now share the data, we have to change or do something with that data. We're going to improve the work we do. It wasn't just, oh, you have the data and I have the data, great. Or it's in some cross report that we do. So this whole issue of interoptability, which, by the way, great organizations called Stewards for Change. If you're familiar with them, I would strongly encourage them. They would be a great thought leader. They have an annual conference, but they're doing work with our state. They're doing work with some North New England states around interoperability with state systems and government systems and local systems. So Dan Stein is a great guy. Encourage him. Once we were also working around our own health and human service data, then we also had the High Tech Act. So the Office of the National Coordinator for the Feds during the Obama administration was very supportive around hospital interoperability. I think there were 13 or 11 communities that were funded 7 years ago, and we were one of them in San Diego. So we share medical data, all medical data except mental health, and I'm happy to talk about that in a second, across all our hospitals, including the VA, including our military hospital, and all of our hospitals except 2 for-profits, Paradise Valley and Promise. They did not want to participate. But our hospitals are all sharing that medical data, and with patient consent. So our hospitals were sharing that. We then began to share that, and what I didn't have, that's a whole nother presentation discussion, and I'm happy to send the folks, or you come down, was around the community information exchange. Can you imagine for a moment? So we're talking about the social determinants. How do they share data? It's hard enough sharing with the medical health data or the government systems. What about the rest? So we have a health information exchange funded by our local foundation that is sharing data across these nonprofits, mainly human service, but some health and clinics. And so now we are connecting, it's called the CIE, Community Information Exchange, with the HIE, Hospital or Healthcare Information Exchange, with ConnectWell SD. And it's possible. It's the realm, look, we're not too far away from states, right? So if we could do it in San Diego, you could do it here. The greatest issue is, do you have enough believers in the room to achieve that? And so for me, having served on the board of the Community Health Information Exchange and also a contributor, dues paying. That's a dues paying because the grant ended and we decided to continue it in San Diego with our own resources, dues. The county is part of that. That has helped sustain for us these Epic and Cerner systems to connect, to now look at how they connect with the social determinants with all the step-down care, right? When you're talking about all your issues about step-down care, well, we're going to need to have that information system on home-based care from discharge. That is what we're building out. Already what's been connected with the CIE and the HIE and creating that crosstalk, which is exciting. This is hospitals saying they're willing to share data with community nonprofits who are doing that type of care coordination. And that's where we are right now. But it took us years to first build, right, that ecosystem of sharing of hospitals, government, and then nonprofits. And now it's coming together. And so that's exciting for us because we know they can't provide or achieve readmission rates without that type of good clinical care coordination. Nor could the jail provide such without that type of coordination with probation and behavioral health and housing and so forth. And I apologize. We have information. I could forward it to you, Liz, so you can, some literature on that.
Is your community information exchange the one? I know you have one that uses your 211 system provider. Is
That's the
that one?
CIE. That's the Community Information Exchange. Yep.
That is the same one. Okay.
Yeah.
Nick, there's a lot to get excited about in the presentation and the work you're doing. The thing I'm drawn to is you've been able to create some continuity over 20 years, which is remarkable. And one of the things I worry about is our short time attention around this work, that to try to be transformative and crosswalk from all the fragmentation to that truly interoperable future. I was wondering, and I think you've sort of spoken to this around the margins in the presentation around the vision and the community building, but could you just kind of hone in a little bit on how you have scaffolded the sustainability dimension to this, both in terms of, how have you helped people see, how you're going to sustain this stuff with resources over time when you're shifting from paying for discrete episodes of care to, social determinants of health. How are you bringing people along on that journey to sustain the model? And then how have you kept people engaged over these multiple years that it took to get the data sharing stuff? That feels so painful. So I just wonder if you could talk about that.
Yeah, excellent insight. Yeah, it is. It's extremely challenging. I'd say, so I could speak in my role of government. It's the fourth role of government that's least understood that I think is perhaps one of the most powerful. And in government, they think of us as the policymakers, and that's extremely important. You have to do that. The second one is the funder. Yes, we do fund for services that county provides through county employees or other services. And as a funder and the service provider, we provide services too. But it's the fourth. That's something the commissioner does exceptionally well, and that is convener. So a convener, you're not dictating policy onto someone. You're not funding that person, and you're bringing your service, your talents and knowledge to the table. And with great humility, it's bringing others, convening others to talk about how we do this together. I've worked back east too, and back east, particularly in New Jersey and parts of New York, the mindset was, territories, TERFs, and I'm hoping that's changed. But government did this, and nonprofits, and hospitals this, and clinics, and it was very difficult I was involved with the AIDS epidemic, and my training in public health, working in Newark, New Jersey, where I cut my teeth in public health, having worked for the Newark City Health and Human Service Department, overseeing their AIDS program, and then being a CEO of a Certificate of Need organization for health, the group that I went to that really stepped up to the plate was the faith community. Because ironically, no one was willing to come together. They were the first to develop AIDS ministries, and to bring this kind of table that they would bring, as a faith leader, a government person, a community, large, nonprofit community, or a hospital, VP, et cetera. And that was my eyes open to realizing, before all of us, the faith community was there and have been, and they're still there. So not pushing any religion, but the issue about that had to be a key spoke. And so that was, for me, public health was, okay, if they can help convene, well, we could do that too in government and what we do. So that's been a cornerstone, really, of our work of how do we convene, and how do we, we are resource-rich, innovation-poor in this nation. And it's tough when rural communities say, you don't have enough resources, the distance. Yeah, you still find things that have not been leveraged together. Postal Service, how are they engaged in your work? Because they should be. And so you start thinking about these other sectors and by doing that, why I'm saying this is important is you bring people together to say, we can share and learn and benefit each other by just convening, without even talking about the state grant on Medicaid transformation and this and that, in and of itself. You do need a backbone, though. You need a backbone organization. This is, Liz and her team. And so, for us, we recognize that. So the county stepped up and saying, we're going to pay for the backbone for LiveWell. It's a staff of about 5 that we do. But for the most part of all that work with those numbers, we don't pay them. So we've reached a point Correct. It was difficult to sustain it, and we were not tied to a start and end on a state grant. But I've been through in my career, it's actually 28 years of working in the government world, seen too many start and ends because of grants. So the thing we committed ourselves to live well was, yes, through the institution, we were government, so we weren't going to go anywhere, but if we were going to do this uplift, it had to be something that could not be tied to just grants. So I'm not sure if that helped answer the question, other than to say, I don't know the role of local government. I think they have to be, beyond the state. Where can they find it in themselves? I've had this conversation in North Carolina. I mean, you're not alone. There's other jurisdictions that are having or at the same place or similar. And what it always comes down to is that I think there needs to be some local investment, because it's about, I hate to use it, local control, right? It's about local control. Now, you definitely want to succeed on your Medicaid waiver, and you want the state, because that's important, and I think you want that to continue. And by the way, waivers always continue, right? Yeah, just so you know. Even with the Trump administration, waivers will continue, but they may be more stringent in where they come. So I think it's great, and Selecki is her name, Secretary Selecki, and I've known her a long time, and just amazing secretary for this state. And she always said, look, she was a strong believer that the state can't do it by itself. And so when you look at from Susan Dreyfus to Selecki to now others in your secretaries, they are always investing in the local area. The issue becomes is, when this grant ends, if it didn't end, would you still come together? That would be a central question that I don't want to ask you, but you ask each other. Would you still come together, work together for the betterment of your five counties? The answer is yes. Then it's having that really clear North Star strategy vision that you developed in 2017. And then how do you build that momentum? Because my other thing is there's probably others that need to be supporting your efforts with other philanthropy and others that I think if they saw this, and I'm sure you already have, but who else can be part of this? I don't know if Providence Health System is part of this. There, okay, that's great. So I think there's community benefit, not to cause you any trouble, but community benefit requirements that need to be invested in this, because you're improving their efforts together. So I think there's real clear strategies, path forward, but it comes down to the amazing leadership of you all. If you believe in each other, we started with a small group. It just grows.
I sort of had a follow-up question for that, but I think you mostly answered it. I think it's a little bit complicated, our region that is. It's a little bit complicated because it's a 5-county, 8-tribe region, but I think you mostly answered my follow-up question, but I have another.
Yeah.
And I was just wondering, since you're further along than us in your transformation, I was wondering if you have any wisdom to share with us, since we're still getting things started.
I actually trying to learn from you, so I'm not trying to be tongue-in-cheek about it. I think we're all on the same journey. And it's not wisdom. I just our beyond live well. It's how do you make it simple enough for people to understand? How do you scope and scale this? How do you get your first win and build that momentum? If I asked you what do you take proud of your major win, what would it be? And then whatever that is, how do you celebrate that? That this is real, this is driving value. Because that will be the magnet status by which others would come. I mean, the commissioner his other commissioner should be fighting over to come to this meeting, right? And all the other commissioners should be, for that matter. And, again, you're very fortunate to having Commissioner Dawson with his passion and his knowledge. But it's how do you get others? And it's going to be, we started the same thing. What's your beachhead? How do you then put that? And you can't be too humble. That's our problem in our field. We're too humble. I'll tell you, the populace loves winners. People, right? I mean, people love winning. And so it's demonstrating. And if it's not something concretely yet in terms of content outcomes, it's clearly demonstrating the value of how you brought people together. And I'm sure you have content outcomes. I just haven't studied that, to be candid. But what is it? How do you focus on that? Because I think if you try to do everything, it may be too daunting. I know you have a huge requirement to your state grant, but it's thinking about the community. And then what I would say is, what is the inclusive vision that brings the 5 counties together? We were one county, but we had 18 incorporated cities. We've had sovereign nations, so we have diversity even within one. You have diversity too, and you have diversity even within the county, right? So then what is that inclusive vision that brings that? And then who is missing at the table? And based on what you heard us, we started health-centric. We evolved. Who should be at the table with you?
Just real quick. First of all, I think it was real helpful that you talked about the heart disease and strokes, because you had something specific with an outcome that probably has exponential financial benefit, which is part of what the goal of the effort is with Medicaid. The other thing is, I noticed you had 211 listed as one of your partners, and there's currently an effort in our state legislature to try to really emphasize and possibly have some legislation to encourage that. Is 211 effective in San Diego County?
Extraordinarily, to the tune that 70% of their budget I fund. We couldn't do our work without them in the way they're constructed. And so if you're in the southern part, if you're near San Diego, I will not steer you wrong. It is absolutely worth your while to go visit, the Live Well Center. So much so, it's not just words, it's deeds. I'm co-located my own other call centers for child abuse and elder abuse there, and trying to co-locate my, virtually, but now because not space, but collate my call centers for eligibility. Our 211 system in San Diego starts our intake process for STEM, the front end. They do our courage to call and dealing with seniors or veterans, in crisis, real time, and linking to someone to help them and link them to services. So they are a significant, not a switchboard, they are really a transformative convener from a digital. And even with all the might of pushing, I think our latest research says in San Diego, maybe 30% of the county still knows about 211. So it's hard because, but when we've had our disasters, they've been lifesavers. Our phones in our first fires, 2014, our 911 system almost went down. 211 was, and Greg Cox, Supervisor Cox, he talks about it. It really was a lifesaver because the majority of people now call 211, getting information where to go. So from a public safety perspective, that alone, from a disaster, 211 is essential. But how you use that in the platform on care coordination and convening and the work that we're doing now, even in terms of placing homeless, and looking at real-time availability for housing beds, it just goes on. So they are a big player for us on care coordination, and that's why they were the natural to build out and take over the CIE, the Community Information Exchange. And we're extraordinarily, excited about that kind of evolution of where they're going. We're still thinking about what more to come from the 211 type system. So, and just for food for thought, 211 serves other counties besides San Diego. So you could switch on to it, and they will, let's say you wanted to be part of they would have a 211 for North Sound ACH for your 5 counties if you opted to. It's better if your state funds it and create your own, but the thing is you can quickly turn on to a 211 system. They don't have to be physically here in terms of their system.
So maybe we need to go to the elementary schools and tell all those kids about 911 and 211, because they're the ones that really keep their families informed. It's important you raise that. When our Chaldean community over the years started coming into the eastern part of El Cajon, one year, our city of El Cajon, population of 50,000, 60,000, had the 3rd highest number of emergency calls behind
LA and New York City. Unthinkable, unimaginable. Why? Because there was a community that didn't come in, didn't understand that they thought to access healthcare or needs, you called 911. So we had to do a massive education and then use 211 and have the appropriate language and support. But you're correct. I mean, the more you can educate, but if you don't have an alternate to tell people to call, then they don't know on it.
First of all, I apologize. I had my eyes dilated this morning, and I
Oh.
had to go in dark glasses for a while.
You look good, though.
Yeah.
You look like from San Diego.
I was
That's all
hoping
right.
you thought I was a celebrity. But yeah. I guess I want to first comment just on the fact that you are a county government. And I think sometimes what I've noticed in our whole transformation, just statewide when we've discussed this, and especially with the State Healthcare Authority, sometimes they have missed the point or missed the value that county governments in particular can bring to the effort, especially in the area of convening and leading some initiatives and culture change. And I was just curious about your particular organization. It sounds like you've got the Housing Authority within, you've got the AAA.
Behavioral health, Medicaid, child welfare, all of the public assistance, the maternal child health. So
Yeah. And so for me, I just see that as it not only forces the collaboration, but I also think it's a great model, even if they are in different organizations, to understand where the partnerships are most effective.
I couldn't agree more. I think, to me, I'm agnostic to the structure, maybe a little biased. I think that I've been working with my friends in Vermont for the Blueprint for Health, and now, gave a talk a couple of years ago, and I'm going back this year, they're doing the Blueprint for Health and Well-Being. And Vermont is one of the leading states in the country on all claims payer, the only that's looking at Medicaid, Medicare, and commercial. So it's truly remarkable. But the issue in the state, and this is a small state, your 5 counties are probably bigger than Vermont, I'm guessing. Only state house I go to that has no metal detectors. You come in and you're like in a classroom and the committee is having its work. It's great. The people are great. Except they can't get their human services, state department, their state run, and public health working together. And so it doesn't mean they have to be an integrated health and human service agency. It just means that those folks have to be, and I guess that gets back to, if you don't have the inclusive vision and the fidelity is to each department, they don't come together. So you don't have to create a health and human service agency so long as you believe in one, in that vision. And that's, not all states have that, or counties. In California, some counties are separate departments, then every county is different. But I agree that it forces that integrated, you're talking about fully integrated, when you're a governmental entity that way, it has influenced the community, no doubt. It's influenced in our Live Well vision, it's influenced our partners. But I just want to mention and say that there's been other work around the country that hasn't been county government, that it was led by United Way, or a coalition or ACH, and that county government was part of it. I get back to that hub and spoke. So yeah, we got it going, but we really now, we're backbone support, but it's the community. We have these regional, because our county's so large, so we have regional Live Well leadership teams. Because what the South County is interested in, this is going to sound familiar to you guys here, the North County has different needs, right? Does it make, right? Your 5 counties? So our county, the East, has different needs than the North and the South and the South. And that's how it should be. It should be. And so, but they all tie to Live Well. But they're working on the priorities of what that community cares about that will differ. But they tie to that inclusive vision. So, it's hard to start to crank, but when you get there, it gets very exciting because there's people that join and they want to do this work. Ultimately, it comes about purpose and passion, not about grants. And that's really what you'll be going to.
So I'm going to take the last question.
Okay.
And I think you've somewhat referenced it, but I would love for you to talk about how San Diego County works with its neighboring counties. So we have 5 counties, and while like the hepatitis outbreak was probably fairly localized,
Yeah.
most outbreaks like measles, they don't actually care about county lines or ACH
Right.
lines or anything like that. And just like, how do you do those things across boundaries? Because people and diseases just, they don't recognize those lines on a map, whether we're talking about county, cities, or ACHs.
Couldn't agree more. And so it's done in different ways. So we have, for example, a Southern California, it's called SACS, the Southern California Counties Human Service, a little bit fidelity to this sector, but all the human service directors get together and talk about policy and practice on human services. We have an equivalent for public health. So they're not sitting like health, human service, like I would love to, but at least the counties are working together. We have a shared academy for workforce, for social workers. Big deal. Saving money, but importantly, it's our regional issues. But I guess our true test is Mexico, then a sovereign nation. And let's not forget our Indian sovereign nations. They're sovereign nations. That relationship with them. And so we have Love Your Heart. We had press conferences in Tijuana, and they were with our press conference, the Mexican delegation. They've come to our events, and we do it at the consulate, or we've gone to their events. Orange County in LA joined us on Love Your Heart, So it's those issues that they care about that tie together. We're always working together. But Orange County in LA has slightly different issues. But I will tell you that, how can I say this? I know all those directors, and we do have a state association, right? It's called CSAC, the California Associations, and then there's Child Welfare League. And so there's constantly coming together for those counties. But our county is just so large, there's a lot in that to just kind of focus on what our 4,200 square miles is. But Riverside County do a lot of work, Imperial County, we've actually provided support to them. It's not even mutual aid, it's just we know each other, we call to support each other. And I think that's probably the indicator of, are you working well together? And I say, if you don't know who those directors are, you probably are not even working together if you don't even know the people are, right? And that also transcends with our electeds. Not all, but some of our electeds kind of know each other, and that's been very helpful as well. So the tone from the top is led, and I think that allows then line staff to understand as they're working, that we work collaboratively with our neighbors to the north, to the east, and to the south, including the military, because we have a huge military. And that's another independent entity, the Navy and the Air Force. So same thing, relationship with them.
So, thank you. Just really appreciate you both taking the time to be here. I think our board and certainly our governance committee, as they've been trying to shape the vision looking forward, has a lot to learn. And can only imagine Tiffany's hair getting on fire when I say we're going to schedule a board meeting in San Diego.
We'd be honored to have you. And just so you know, on that list, we do innovation tours. For our partners, we consider you a partner. So the only requirement is we learn together, because we don't profess to have the answers all in San Diego, and we're on the same track. But we'd be honored to have you and to meet some of our community partners as well. So it'd be great to do that.
Thank you so much.
Thank you.